Everyone, we are back on air after our practice evacuation drill. Bobby, sorry we left you without telling you, but that's what we're supposed to do, right? So it all went well. So this afternoon, we have Ameren and Nolan back with us to do another 101, and this is on the health insurance industry. And I am going to, before we start, ask Sarah, who's here, just to introduce herself, because I'm not sure you've been introduced to our committee, and we'll have her at some point come in and testify.
Great. I'm Sarah Ticho. I'm the Director of Government Relations for Blue Cross and Blue Shield.
Great. All right, I am gonna turn it over to Nolan and Ameren.
All right. For the record, Nolan Langwell, the Joint Fiscal Office.
Ameren Abergele, Legislative Council.
So our goal today is to give you a very, very, very high-level overview of just some basic health insurance, some terms. We'll talk a little bit about some of the regulations, but this is really a light touch to start throwing, again, some ideas and concepts at you so that when you hear more about them, you have some foundation. We're not going to get into the weeds if possible. I mean, you can obviously ask questions if you have them, and we will answer them to the extent that we know them, or we might even have to phone a friend. But otherwise, for the most part, really a light brush, foundational, to help start and getting you up to speed on some of the concepts. So what we're going to talk about is health insurance with a high-level market overview. We'll talk about self-insured. We'll touch upon the difference between an HRA, an HSA, and an FSA. Then we'll talk about some insurance basics, such as actuarial value. This is something you will hear a lot about. Basics like cost sharing, risk pooling, and premiums, and then a little bit on rate review. There's a lot of other stuff that go into health insurance, but really, like I said, trying to hit on things that you're going to hear a lot about: actuarial value, pooling, premiums, cost sharing. These are things that you will hear a lot about, and many of you may know this from either being on the committee or Representative Chena is a practitioner, as Representative Cordes, so they're very familiar with this stuff. But nonetheless, we'll just go through it.
Right.
So I threw this chart out. This is from the expenditure analysis, the Green Mountain Care Board. We're not going to go through it. You don't have to memorize it, but this is a good thing for you to have access to. So I've shown you pie charts, but I haven't given you numbers. And so when we talk about how many people are on the individual market, or the small group, or the self-insured, or the large group, or Medicaid, this is where you can come to get some of those numbers. And I like that it's got a little bit historical, so you can see some of the changes on it. So this is really meant to be a reference point. What we do not have a lot of stuff, and I'll get into some more, is HRAs, HSAs, and FSAs. And again, we'll get into what those are. But those are sort of no, I won't go there yet.
Can I ask the question? Oh, forget it. I answered my question.
Okay. And Ameren, jump in at any point. This is a chart you've seen. This is just sort of an overview of the private commercial insurance market. I won't spend too much time on it, but this is really just kind of, as I said, my presentations they try to tell a story, so I'm just kind of walking you into it a little bit. And, but we're talking about private insurance today. So again, you've seen this slide, but just a reminder, approximately half of Vermonters have private insurance. Most of those plans are through employer-sponsored insurance. You may hear the term ESI, ESI. Some people talk about ESI. They're talking about employer-sponsored insurance. And then about 3/4 of those plans are self-insured plans. So we'll get into what that is. This is another slide that I have shown you in the past. Again, repetition is good. I believe in it. So the difference between an insured and a self-insured, an insured, they bear all the risk, all the financial risk. The employer purchases the coverage from a regulated health insurance company, and the insurer is subject to state regulations. Self-insured, the employer assumes all the financial risk, may utilize what's known as stop-loss insurance. That's sort of like insurance for insurance. It kind of protects, let's say the policy is up to $1 million of lifetime and someone goes over it. This is a way to, actually, can you explain stop-loss better than I can?
Possibly. So an insurer is, the employer.
Sorry, Ameren, can you just say your name for the record? Did you do that?
I did.
Okay, sorry.
I can do it again. Ameren Abergele, Legislative Council. So when you're looking at an an employer who is self-insured, they are going to pay the cost for whatever the healthcare costs are for their employees. They may at some point realize if the costs of providing health insurance go beyond, say, and they say a set number, $1 million, $1.5 million, that's too high for this company to be able to cover, especially maybe a smaller company. They may purchase stop loss insurance so that they are insured in case those costs go beyond what they're anticipating those costs. If, for example, they're a small employee and they've had consistent healthcare costs, but then one of their employees has a very costly medical experience, cancer would be a good example, and very high cost prescription drugs that may put them over what they know they can afford, they will purchase that stop loss insurance to stop their loss at a certain price point.
Articulated way better than I could.
So we have Brian and we have Art.
So I looked ahead, and I don't think this is answered, which is why I'm asking now, because it's clarifying the previous slide. We don't have to go back on there, but I'm going to read what I see on the previous slide. Like, it says half of Vermonters have private insurance. Most are through an employer-related source. About 3/4 of employer-sponsored insurance are self-insured. So what I'm trying to figure out here, though, is when I look at that pie chart represents about half of the people in Vermont, right? Like that one in the corner of the screen up right now. So 3/4 of half of the people in Vermont have this self-insured. Is self-insured mean here? And I'm trying, because I was trying to figure it out. Though that's not people who like individually buy into the exchange. Those are people who get it through work. So
The type of insurance through work.
a type. So like other employers are purchasing the large group or small group insurance.
Yes.
And where would like me, who's like a private practitioner who buys from the exchange, are we the other?
No, you would not. Yeah, you'd be underinsured.
I'd be what?
You'd be underinsured. So you're buying an insurance policy.
Yes. So where would I fit in here? Like under that 4%?
You would be.
That purple? So
No, I'm sorry. We're talking. This is employer-sponsored insurance. So you wouldn't be on this chart at all. If you go back to the next slide, you're in that yellow individual market.
Thank you. Yeah, that's helpful. I'm just trying to understand where we all fit. So, because then when we look at that pie chart, what it's showing is, so it's like less than half have employer-sponsored insurance.
Go back one more.
The charts are.
Employer-based, I mean.
So.
And then the small employer are buying in. So I'm saying like.
So you're letting it. So the chart is a little deceiving, isn't it?
Okay.
My apologies. I think I might have just used an older version of the chart for time's sake. But we know 49% of Vermonters have private insurance, so that's all. That's the everything in the gray, right, including the military, we'll say. Then we're saying, okay, pull out that individual. So it's to drop that individual market, and I think it's 30,000 people or so like that, and so it's the light gray. So that's what we're talking about when we talk. So the pie chart is, so this is that.
Yes.
Not including that.
Okay, yes, thank you.
My apologies for the lack of clarity.
And so the first blur, approximately half have private, that's all the gray.
That's all of it.
That's all the gray. Okay, and then,
Then you pull out that
Right.
chart, and then we're saying 3/4 of this. This is all that.
So can I just, this is where I'm getting at, and if you don't have the answer now, you can tell us later because we see you all the time, is what percentage of Vermonters have health insurance that we cannot regulate? Because it's that ERISA, that's what I was trying to figure out from this. And maybe that is up ahead and I missed it when I was looking.
That percentage.
Thank you. We can come to it when you get there then, thank you.
And
I don't
that's,
have a number on that, but that gives you the visual without the number.
and that is a reference point we need to keep remembering in that.
Yeah, we'll come back to it, thank you.
Yeah.
So
So,
the colored part there is the only part we don't regulate.
well, the color part is the part we do regulate.
Okay.
And then there's Medicaid.
And then there's Medicaid.
Different, there's Medicaid.
And then Art, did you have another question?
Yes, I had a question.
Without getting into Medicare Advantage and
Right.
stuff and all those other pieces, because I can feel Sarah in the corner there. Sorry.
I'm trying to understand the self-insured.
Well, that's where we're at. So I can either finish talking or you can ask me a question either or.
Well, I just, I get the insured,
Mm-hmm.
you buy insurance.
Mm-hmm.
The self-insured, so a bigger company buys from various insurance companies.
So let me take a stab at it, because that's where I was going, so it's a perfect segue. So if you're a large company, usually there's small companies do self-insured too, but it's more common in large companies. You might be a larger company like, we'll just say Global Foundries, right? Well, let's make up a company. Vermont Mug Company. They have 1,000 employees in the state of Vermont. They say, you know what? We think it would be cheaper for us to do a self-insured plan rather than pay premiums on 1,000 people. We think that what we can do instead is maybe we'll have a corporate wellness program so we can help manage their risk, get them to go running once a week and we'll give them $5 or whatever. They have all these programs. And instead, we will hire what's known as a third-party administrator. Now, Blue Cross Blue Shield has TPA products. And what they'll usually do is they'll sell a product saying, well, you'll still get a card, third-party administrator, thank you. You might have a card that says Blue Cross Blue Shield on it, but it's still there. That's because your company is buying a Blue Cross Blue Shield product, and usually they're pre-prepared, right? So it'll have, different programs and deductibles, but you buy that product, right? And the difference is that they're just adjudicating the claims, but it's still the money instead of the insurance company, like I'm paying you to take on the risk. Normally, if I was a regular insurance product, I'm paying insurance company the premium to take on the risk. What they're doing here is saying, we'll take on the risk. We'll hire them to adjudicate and to do some administrative stuff, and they'll use their already established physician networks, et cetera. But we think that it's cheaper for us to pay the claim than it would be to pay a premium. So it's a business decision.
So if I when I go to the doctor under that plan,
They won't know.
They won't know.
They won't know.
they what?
They won't know the difference.
They won't know the difference.
But the doctor would bill the company instead of the insurer.
They'll go to your card, they'll see your group, they'll say Blue Cross Blue Shield on it because that's my third party administrator. They'll just bill through that, and then Blue Cross will adjudicate it properly. They'll say, okay, it's a self-insured plan. They'll do whatever they do on the back end without getting into the weeds of how it works.
But they would then come to the company.
Yes.
Yes.
That's part of the agreement with the company.
Okay, all right, okay, I get it. I didn't know the flow, I get it.
Yeah. So that's the difference. But so it's just really about who assumes the risk, right? So if I'm buying an insured plan, I have 100 employees, I'm just going to buy a small group plan or a large group plan. 110 employees, I'm going to buy a large group plan.
Yeah.
I'm giving the insurance companies and they're going to take on the insurance risk.
Right.
Versus we're going to do a self-insured plan and say we're going to take on that risk because, my predecessor used to use this analogy, and this is where we get into pooling, but we'll get a little ahead of ourselves here. You have two populations, right? My mug company, it's not really mug company. My company is Aerobic Instructors of Vermont, right? Probably pretty healthy population versus my company is the Coal Miners of Vermont. Probably not as healthy, right? So it's a bad example, but that's kind of a precursor to kind of an over-exaggerated example of pooling. So in this case, the employer might say, I got a pretty healthy population, they're educated, they're fit, versus, and that's the businesses, and I don't want to get into it. And,
Right.
So I think we're good with that, Joe.
I just wanted to make a comment. I had an insurer, a company I worked at for several years, use that. From a consumer perspective, patient perspective, it was completely seamless. I didn't even know for years that we were under one of those insurance.
Right.
Yeah.
Right.
Yeah.
But my only question was how the money gets back to the company you explained.
yeah, and that has to do with the risk. So the third-party administrator will work with and they have a whole way of.
Sure.
The other big difference between insured and self-insured is with insured, those plans are subject to state regulation. So again, if we say you have to cover colorectal screening, if we say you do, they have to cover it. Self-insured plans are not required to because they're preempted by federal law. We talked about ERISA last time.
That's important.
Most of the time they cover it anyway, but they don't cover it because we tell them to. So, anything you might want to add about self-insurance? That was complicated.
Can I just, did you just say most of the time they'll cover it, but not because we tell them to?
Yeah, a lot of times we've
Yeah.
like, we've had there's been, when I've been here in the years, we've done stuff where we want to mandate something, mammograms, for instance. And then we would talk to the insurers, like, well, Global Foundries already covers that. We found that a lot of these cases, some of these self-insured have a lot of these things we want to mandate already in the past. So they may do it regardless of whether we tell them to or not.
Have you know, and once again, if this can't be answered today, you can come back with this answer in the future, but when Vermont mandates or requires insurance plans that we have the power to regulate, when we require them to do things, do some of these ERISA plans sometimes follow suit because they see that, now in Vermont, maybe the benefits of the public plan are competing with the.
I don't know that we have done anything new in a while, and that has to do with, under the Affordable Care Act, we really didn't do any more mandates. Any new mandates we did, the state would have to cover the difference. That had to do with the qualified health benefits and other stuff, not to get into the weeds of that. So I don't know that we've done anything recently where the self-insured have followed suits. Maybe, can I phone a friend on that?
Last year, you.
Sarah, can you just say?
Sorry, Sarah Teachout with Blue Cross and Blue Shield of Vermont. So last year, the legislature added hearing aids as a mandated benefit. So that would be an example of something that you recently added. What we typically do is we ask all our self-insured employers, would you like to also add this? And we give them an idea of how much additional cost it will be for their particular population. And I would say a lot of times they want to offer what you can get in the public marketplace, so they often add it. Hearing aids has been a little bit of an exception so far because it is so much more expensive than others. And then there are benefits that private employers want to offer that aren't part of the public plans that they offer on their own. One that I can think of is fertility benefits. So some companies want to offer those for their employees, and they do that even though it's not a mandated benefit.
Thanks, Mari.
And just for clarity, there are the essential health benefits from the federal government that you alluded to, and I think mammograms are actually one of the required essential health benefits at no cost to the person getting the mammogram. I don't know how many, there's 8, 10, 12
Mandates,
essential health benefits
Yeah, I don't
that
remember.
are required to be allowed to be in every plan.
Yeah, and that had to get to when we established essential health benefits, you had to create a benchmark plan. And I think we used the state employee plan, and that had mammograms in it at that time.
Self-insured plans don't have to cover those mandated services, do they?
Even at the federal level?
Yeah, even at the federal level.
But they were, okay.
So, and let's stick with insurance
Yeah.
for now, and we'll,
Yeah,
if there's questions on that, we can find out later.
but it's a good conversation because
Yeah.
self-insured is complicated.
Yeah, it's very.
And we start getting into, ERISA, and that gets complicated fast. So, quick note about HSAs and HRAs. Don't ask me in-depth questions about these because I don't have one, so I'm not an expert on them, but I can do the high level. So, but they are an important piece of our healthcare system. We're seeing more and more employers move away from like a full, like high or low deductible, like large employers move away from low deductible plans to high deductible plans with HRAs. For instance, I know that for the city of Montpelier, they changed the benefit structure so that they had a high deductible plan, but they were using an HSA or an HRA to offset it. So essentially the out-of-pocket exposure was still the same for the employees. So
Before you go any further, I just want to be clear on the terminology. So premiums are what you pay each month to have the insurance, right? And then deductibles okay, great, sorry.
I'm getting ahead of there's no right or wrong
I know.
way to do this presentation.
All right, can you do this before you then do the HSA?
Yeah.
That'd be great.
So let's do some terminology. Yeah, there's no good way to,
No.
everything sort of preempts everything else. So cost sharing is when a user of a health plan share in the cost of medical care. So deductibles, co-insurance, co-payments are examples of cost sharing. So a deductible is the amount an individual must pay for a healthcare expense for insurance or a self-insured company covers the cost. So for instance, I have a $500 deductible, or we'll say $1,000 deductible. And I go in to get a procedure and it's 200 and we'll say it's $500, right? Well, I have to pay that $500 until I have in that 1 year service, 1 year of my coverage, which is usually calendar year. Once I hit that $1,000, then I hit my deductible and I don't have to pay. But then you might get into co-insurance or co-pays. But that's the basic idea of the deductible is it's how much you have to pay until other pieces of the insurance policy.
Yeah, I would say once you hit your deductible, usually is when your co-insurance starts coming into play, which is the next.
Why don't you take that one, since we're moving in.
So co-insurance refers to the money that an individual is required to pay for services after the deductible has been paid. So this will mean you go in, you have, say, 3 procedures over the year, you've met your deductible, you come in for a 4th procedure, and your plan says, for example, for after you meet your deductible, you are going to cover 20% of the costs of any more services you have for the rest of the year, assuming there are some caveats to that. But as a general idea, you would then start paying 20% after that, and your health plan would cover the other, say, 80% of it. And then you have co-payments, which you're probably all familiar with. To some extent, you go to the doctor's office for a regular visit, you have the flu, you've got a cold, you have a $20 or $25 copay. These copays don't usually go towards your deductible, right? These are standard out-of-pocket costs that you're going to have as part of your insurance. So they don't usually count towards your deductible, but they are fixed payments that you are going to make for a visit. And this is also true usually of prescription drugs. You go in and you know that well, actually, that could, I guess, be co-insurance or co-payments, but those are our 3 basic categories of cost sharing. So whenever you're looking at a plan and figuring out how much are my out-of-pocket costs going to be through this plan, you're looking at what are the deductibles, what are the co-insurance, and then what are the co-pays that you're looking at.
So
Can I just interrupt real quick? And so on deductibles, there's also what's called high deductible plans now, where so you might have, let's say Nolan has a plan where it's a deductible of $500. A lot of the plans now have high deductibles. You're looking at $7,000, $8,000, $10,000. And then I think we'll get back to the HSAs and HRAs, and that's where that kind of comes into play. Sorry, Nolan.
No. So in that conversation, here's an example of the standard plans in Vermont Health Connect. These are on exchange plans. So you can see, and I'll get to the bronze, silver, gold, platinum in a second, but you can see on the bronze plan, it's got a medical deductible of $6,450, or a prescription drug deductible of $1,100. Then you've got your medical out-of-pocket max, so that would be the total amount. So you might pay, you hit your deductible, then you hit co-pays, and you paid 80/20, so you hit 9,100, then then you don't pay anything after that. And then you have, and then you can also see you might have an office visit. You might have to pay $35 for an office visit, $90 for a specialist, or you pay 50% for the ER. Then you've got a prescription drug. At the bottom, you'll see I've got the premium. Premiums do not count towards your deductible. A lot of people ask that question. Does my premium count towards my deductible? They are different boxes. The way I like to look at it is your premium is what you pay to get your deductible. So, anything you want to add?
Would that be almost like a catastrophic, considered catastrophic coverage?
I don't remember I think catastrophic is probably in the $10,000 range. That's, for folks that I think I'm young, invincible, I'm going to pay a low premium. I don't think I'm going to get sick, so I'm going to take my chance. And it's only going to pay if I have a catastrophic incident, which is $1 gazillion.
Right, I know what it is. I didn't know what that called for.
So I'm going to, I'll come back to the HSA or HRA. I want to go into actuarial value.
can you, I'm sorry, if you're covering this, stop now. Bronze, silver,
That's what this is, right?
okay, perfect.
So, actuarial value. You know, it's funny, I did this presentation once. I threw this together a couple years ago for Chairman Lippert. And now we're walking through, I'm like, I would totally reorganize it differently. But, so my apologies, you guys.
No, we're just asking questions.
No, it's fine.
It's there.
This is good. This is, so actuarial value is basically how, it's the average share of medical spending paid by a plan for a defined set of benefits covered, a set of covered services across the population. So for instance, if a plan has a 70% actuarial value, on average, the plan will say pay 70% of the medical spending for the covered services, and the beneficiary would pay the remaining 30% through out-of-pocket, such as deductibles, co-pays, and co-insurance. So the higher, so you look at the bottom there, the higher the actuarial value, the lower the cost. No, the higher the cost, and vice versa. So what the Affordable Care Act established metal levels, I can't seem to say it today, for plans. And so platinum is a 90% actuarial value, gold is an 80%, silver is a 70%, and a bronze is 60%. Now, there's a range in there. It's roughly 88 to 92. It has to do with where the plans fall in. But ultimately, you know, we just sort of say 60, 70, 80, 90. So if you looked back at this thing, this is what a bronze plan would look like versus a platinum plan. And you can see a bronze plan has a medical deductible as for an individual of $64.50, and you pay $640 for it. But if you want a platinum plan, well, I only have a $425 deductible, but I'm paying $1,130 a month. So the higher the actuarial value, the higher the cost.
The higher the premium.
Higher the premium, yes.
And I just wanted to mention, when we're looking at these metal levels, we're talking about those plans that are in Vermont Health Connect. We're talking about individual and small group market.
Thank you.
So the actuarial value is set on the metal levels by the federal government?
Yeah, under the exchange plans, yes. Well, in terms of, so, and how do I describe this? This gets in the regulation about what the insurers are required to offer in the exchange. I don't know if I can answer that question, but that's how we define the plans. And the cost is associated with that plan. So some folks might say, okay, a bronze level is going to have the lowest deductible or the highest deductible, but it's going to cost the least. And so this is where you get into the consumer choice versus I want the best plan possible. I want the highest actuarial value, but I'm willing to pay for it. But they're sort of on the exchange, they came up with these metal levels because they tied their subsidies to those levels. So they sort of had to define them in law, subsidies. But, you know, if you're outside the exchange, people don't call it by that level. Or if you're a large group plan, they're not really calling it a gold plan. It's really sort of an exchange dynamic for how they were defined. Anything, am I answering that question okay?
I'm not sure I quite understand the question. When you say set, what do you mean set?
A percentage. Like the platinum must be between 88 and 92%.
Yes, that's a federal requirement.
That's a federal requirement.
Where a specific plan falls within that range is part of the process that happens at the state level. This is getting maybe more into the weeds than.
That's I think that's what my brain's doing though.
Okay.
I'm working through the mathematics of what the average medical spending is each year. And I'm watching the rates increase at high percentages. And I'm also watching the cost share for each metal level also increase. The deductibles on everyone are going up. The copays are going up. And I'm trying to wrap my brain around that we're still falling in, say, I mean, I'm on a silver and I'm still within 68 to 72% of the.
So there's other pieces that go into plan. So So in this one, you might have a plan that has for instance, we'll say a silver plan, $4,000 deductible. There may also be silver plans that have a much higher deductible as an example, and you might look, but that's because they might have a different medical, they might have a different out-of-pocket max, they might have a different prescription drug plan, they might have so there's other pieces. People sort of look at the deductible as the first thing they look at, but there are a lot of other things, like it might not cover certain services. What's in that plan. So there's other pieces in that plan. So they might say, okay, I'm gonna have two silver plans. One has a $4,000 deductible, one has a say $4,500 deductible. But that's because that plan has a little bit different set of services that it might cover, or the out-of-pocket max might be a little bit different, or the prescription drug piece might be a little different. So there's multiple things that go into a plan. And the 70 or 80% is the average cost for that plan on average. So it's not just the deductible.
I understand that.
Add on to that.
And I also understand there are multiples of each level.
It's usually
But if you compare each level year after year, the same set of coverages, you watch each year, those copays go up every year. I mean, the silver went from 35 to 40 this year. The year before it was 30. The year before it was 25. And then you're also watching incrementally the amount of the deductible on the exact same silver plan, not comparing against, the reflectives and the this and that. But it was just I'm trying to wrap my head around actuarial value and trying to put that into the mathematics I'm calculating in my head.
We're gonna phone a friend.
Yeah, we're gonna have Sarah. I'm sorry.
Sarah Teachout from Blue Cross and Blue Shield again. As the price of healthcare services goes up, in order to keep these AV values in line, the out-of-pocket costs have to go up too. So if it costs $10,000 a year on average for someone's health insurance, and you're at an 80% AV value, they have to, on average, pay $2,000 out of pocket. If the price of that exact same set of services goes up by, I don't know, if it doubles, let's make it easy, if it goes up to 20,000 on average, then the out-of-pocket cost has to go up to 4,000 on average. So we're forced, because we have to make these metal level ranges, to increase the out-of-pocket cost to match the rising cost of medical services. So that's why you're seeing it go up.
No, I had done that calculation in my head, and that was the thing that was alarming me.
Yeah, and it's going up quickly.
Joe?
I was just wondering, percent of what? So are we saying percent of, on average, some of the platinum plans should expect to see 90% of their costs covered? Or are we saying on a population level, all those with platinum plans ought to see 90% of their cost covered, or something else?
That's what gets into the, I'm gonna go, Sarah's linking at me there. I should, okay, I'm gonna take a second and tell you my actuary joke. Because it's getting.
Is it better than the Medicaid one?
That's
Like,
Seen one Medicaid.
I know.
well, this is one of those jokes where it's another one of those jokes that gets funnier and funnier as you get it. The two actuaries go hunting.
You know we're on air, right?
I know.
Okay.
I probably should explain.
Okay.
Two actuaries go hunting. First actuary, they're going duck hunting. First actuary shoots it. Boom. Just misses it by the nose. The other one shoots it. Poof, just misses it by the tail. They high five. We got it. Right? It's a range. It's an estimate.
Better than the Medicaid joke.
Yes.
Okay.
Because the bird has a heart attack.
Let's keep going.
Hey, that was my comment for today because I feel like I'm flailing. I'm flailing here. No, he was talking about, but at least he was funny. Gosh. Okay. So we're done with actuarial value.
Yep.
And again, this is one of those concepts. It is complicated, and it's the more you get into it, when you start hearing about exchange updates, and you're hearing about bronze plans and gold plans. Again, I'm not an actuary. I'm not an expert.
1 second.
It's fine.
You good?
Yeah, no, it's fine, Mike.
I just think one point.
Can you
that-
recognize yourself?
Mike Fisher, healthcare advocate. I think one point that was important for me to understand when I was learning this is that the AV calculator is a federal calculator. It is not Vermont. It's not about the Vermont population. It is a national average. So don't think that you can do something here in Vermont with health policy to affect the ABO.
And where this is gonna come into play in conversations is we will have insurance companies come in, or Greenback Cohort or others, and we'll talk about, if we are, when Sarah talked about doing hearing aids, so we want to mandate hearing aids, how does that affect, the actual value? How does that affect premium? So we're not going to need to be experts in what an AV is. We just need to understand the concept and keep it in mind when we're looking at decisions we're making.
Yeah, and what goes into, I should have said this before, what goes into a plan to come up with actual value is complicated, but really the idea here is just to give you a sense of it. We're talking about 7% actuarial value. This is kind of what we're talking about. We're talking about 80% actuarial value or goal plan. This is roughly kind of conceptually what we mean. I didn't really mean or want to go down the rabbit hole of what is in a plan to make it gold versus silver, but I was just, so didn't mean to go down, but.
That's okay. No, it's good.
But I think it's a good time to move on to risk pooling. So pooling of risk is a fundamental concept of insurance. I mean, that's what insurance exists for. A risk pool is a group of individuals whose medical costs are combined for calculating premiums. So we talked about, you're going to hear about pools and risk. You're going to hear some conversations about combining emerging markets or unemerging markets. This is that idea that allows higher costs of less healthy people to be offset by the relatively lower cost of healthier people, either in a plan overall or within a premium rate category. The general thinking is that conceptually, ideologically, the general thinking is the larger the pool, the better the risk. There's a term called community rating. Actually, Amber, why don't I let you do the legal right here? How about community rating and guaranteed issue, if you don't mind?
Sure, I'm less familiar with guaranteed. Well, let me back up.
I'm sorry, I
Okay,
didn't catch
so,
that.
no, that's okay. Okay, so the idea is that with pooling your risk, the larger the pool you have of people, the easier it is to anticipate what those costs are going to be, right? Because a huge jump in one person's healthcare cost will make a big difference if you're only looking at 100 people, but if you're looking at 10,000 people, then that one person's jump in costs may be offset by a large number of lower costs by other people for the year. So that's when we're talking about risk pooling. We're pooling those risks of how much is it going to cost to pay for the healthcare for this pool of people. When we're looking at community rating, this is when health insurance providers are required to offer health policies within a given territory at the same price to all persons regardless of their health status. So we know that certain populations of people are more likely to have higher healthcare costs. Smokers, as we age, generally our healthcare costs go up. So when you require community rating, you are saying that anyone in this pool all has to be charged the same amount for their health insurance, regardless of whether they are a 60-year-old smoker or a 20-year-old athlete. So this is a way to, this is a choice that Vermont made when starting the exchange after the Affordable Care Act was enacted. Vermont had to decide whether to do community rating for everyone based on regardless of their health status, or there are certain categories that states were able to break up the community rating so that you could treat people, for example, who are smokers different than people who are non-smokers. Vermont, when establishing our markets back in 2014, chose to keep everyone the same regardless of their status. And then when we're talking about guaranteed issue, so long as the person applying for health insurance meets eligibility criteria, the insurance company has to provide them with the plan. They can't say, you are too expensive. We know for the last 5 years that you've had all of these health complications and you've had a lot of services. So long as the person is eligible for that plan, then the company has to issue that plan. And in this instance, we're talking about on the exchange, Vermont Health Connect.
Is guaranteed issue the same as ensuring that everyone is covered whether or not they have a pre-existing condition?
I am not sure.
Okay, that's fine.
Yeah, I mean, I would say that,
Probably, yeah,
you can't discriminate,
right,
you
based
can't
on,
not offer insurance based on,
right,
or change your
right.
health premiums based on your medical history.
And so the general thinking has been that the larger the risk pool, the more predictable and stable premiums can be. However, just because you have a large risk pool does not necessarily mean you're going to have lower premiums. Again, to go to that concept of the aerobics instructors versus the coal miners, you might have, 100 aerobics instructors and 1,000 coal miners, or so there are other factors that go into it, but we're talking about stability of it.
Are the risk pools that are offered for health insurance plans in Vermont only made up of Vermonters, or are those risk pools spread out over groups national?
Those are Vermont pools, and it's actually a good segue into the next page. So Vermont was one of only 2 states that had merged its individual and small group markets. Currently, they've temporarily unmerged, and so when they will remerge on January 1st, 2024. So we have 24,000 people in the individual group. We have 45,000 in that small group. The individual group right there at 24,000, they're one pool. The small group, 45,000, are another pool. They were merged when we first did the Affordable Care Act, they were merged. They are temporarily unmerged for a very technical reason, which I'm not going to get into at the moment, because that will only confuse you more. But this committee will be tasked with having this conversation, because I'll throw this term out, you're going to be hearing about a term called silver loading, and this committee will need to weigh in on whether we continue to merge or remerge the markets depending on federal regulation. So there's the commercial for a future event. You will be having this conversation. This is really meant to just help you get there, or maybe I'm confusing you more, hopefully not. And there's different reasons for why you would merge or the individual small group versus unmerge them, and we'll get into that.
How about why was it merged in the beginning?
It was merged in the beginning because the idea of the larger the pool, the more stable the population. Prior to the Affordable Care Act, our individual market was under 2,000 people. And then with the Affordable Care Act, things changed, markets moved, people dropped, people engaged. So it really shook up, I'd call it shake up the snow globe a little bit. And so the idea is that the more people you have in a population, the more stable it is. Now, some would argue 24, 70, they're still both very small. That's a whole other conversation. Adverse selection. Is there a question?
No, I did not.
Okay. Adverse selection, this is a really important concept. So when an insurer or a market as a whole contains a disproportionate share of unhealthy individuals. So a common example would be when you have people that are allowed to wait until they know they are sick and needed health care before purchasing a health insurance policy. If you allowed people to buy insurance only when you need it, then the people who are sick would be paying, and the people who are healthy would not be paying, and there wouldn't be enough money. The idea behind adverse selection is to come up with ways that everybody's paying in so that there's enough resources that not just the expensive people are paying, but everyone is paying. And there's various policies that have been put in place over the years or considered that would try to reduce the adverse selection. There was talks of individual mandates and stuff like that. So again, the more people in your pool, the better. If you only have the sick people in the pool and you keep the healthy people out, the premiums are going to be really, really high versus non-sick people paying in but not using the services.
I want to add on to that. You also have the situation where you have plans on the exchange, and when consumers go, they have a whole bunch of options for what they decide to purchase for their health insurance. It may be that one insurer has plans that tend to be more favored by different populations of people, but depending on their health needs. So you could have a circumstance where it tends to be that the, 60-year-old who's just retired but not quite eligible for Medicare and wants to purchase their own plans all tend to gravitate towards one insurer's plan because for whatever reason, just how the benefits are structured or the co-pays look, that seems like their plan. And so you might have one insurer then on the exchange who has a disproportionately large share of the people with higher costs in healthcare than the other insurer. So I just wanted to know that those dynamics are in there, which is how we segue into our next topic of risk
Why don't
adjustment.
you keep going with that? Keep going, you got this, if you don't mind.
So under the Affordable Care Act, CMS collects funds from insurers who enroll in more low-cost health people and distributes them to insurers who enroll more high-cost people. After so it's interesting because we're going to get into rate review later, but when insurers are looking back on who enrolled in their plans last year, they can see where the sort of unexpected adverse selection happens. The data from insurers is sent to the federal government, who goes through and does their analysis and says, insurer A, it looks like you had a disproportionately large share of higher cost individuals enrolled in your plans, and insurer B, you had a higher percentage of people with lower cost. And so what the federal government does then is tries to even out what happens for each insurer, right? Because each year, an insurer's premium for the next year are to anticipate what they expect their costs are going to be based on the populations of people who have been enrolled over the last however many years. So if one plan starts, I don't want to say collecting, but keeps attracting populations of people who have higher costs, the premiums for that health insurer are going to need to keep climbing to make up for or to keep up with the rising cost of care for those members. So then you start having an uneven, a more uneven swing in how the premiums go between two insurers. So each year there is this risk adjustment, again, calculated by the federal government, that tries to even out and eliminate that adverse selection shifting that sometimes happens.
And again, this would just be at the Vermont level, not a national.
Just at the Vermont level, and we're just talking about those plans in Vermont Health Connect.
It tends to be this concept that you want to have as many players in the field as possible. If you only have one insurer, there's not the competition. There tends to be that piece. Now, I'm not saying that if Blue Cross were the only insurer that they would have super high premiums, but there is a sense that people want choice and that there's some level of competition does help. But that's sort of an underlying concept.
And at the same time, though, we are such a small state with smaller numbers, it makes it difficult to have a lot of insurance companies because the risks are so, the pool of people are so small. So it's.
And a couple of years ago, I was doing research on something, and in other larger states that had insurers sold at a county level, there were some parts of some of these states that didn't have any plans that wanted to be in the exchange. And that was creating a real problem for people in terms of getting coverage. So we're lucky that we have at least two plans in our exchange. Move on to something a little lighter. Health insurance premiums. So there's a lot of factors that go into a proposed premium. When the insurers when they try to calculate what their premiums are going to be and they propose them, we'll get to the regulation piece. But what goes in a premium is projected medical and pharmaceutical costs. So this is where the actuaries are trying to figure out, okay, how much is the premium is going to be. They look at the projected medical and pharmaceutical costs. So they'll look at what the trend has been for their population or each of the different pools, and then try to project what you think those medical and pharmaceutical costs will be in the future. How many people they expect to be in that risk pool, as well as the experience of that particular term experience. experiencing claims. What are the administrative costs of actually running the product? That might include product development, sales and enrollment, there's claims processing. These things cost money. Customer service, you got to pay for someone to be on the line when you say, oh, I got billed for this. Contribution to reserves. This is an important concept. I think we get into it a little bit more, but basically this idea that you want to have, we want these companies to have some reserves in case they don't hit their projections. We don't want them to go out of business. If they claim that they were going to have this much claims and they have this much, you want them to have some foundation so they don't go bankrupt, right? And there's a lot of rules and regulations into that in terms of solvency, making sure that our companies remain solvent. And then you have regulatory compliance. The insurers, they spend a lot of time and money going before regulatory bodies trying to explain their premiums. We also have taxes and assessments and fees, and some of these are federal, a lot of these are state. And we have a claims tax, for instance, that we apply, and we use that to help pay for Medicaid. And then there's there's also there's a premium tax, which is on all insurance, not just health insurance. So there's different taxes. When those get built into the premium, there's laws and regulations. So like there's things that the products have to have, things that they have to do, and they have to pay for those products. And what's in the plan design? So again, actuarial value. What's the deductible? Is it covering dental? What level? Not dental. Transportation. Is it covering whatever? Like what's in there? And then market competition. Again, like okay, what's my competitor going to do? I don't want to be so far off the mark. But remember, the insurers, like the premiums are how they stay in business. So they're trying to sell you a product and they're trying to stay in business. And so they're trying to figure out how do I make sure that I'm covering my costs and putting money into my reserves and being able to pay the claims. Anything you want to add to that?
The only thing I'll add that when we're looking at projected medical and prescription drug trends, we're looking at trying to estimate what is going to be the cost for each of the services based on what has been the cost for those services over the last few years. And then what does the insurer think that the utilization is going to be? How often do they think this particular group of enrollees is going to use those services? So I just wanted to mention that.
And so another term, and I'm not going to get into too much, but you'll hear medical loss ratio or MLR. And that's basically the percentage of premium an insurer spends on claims and expenses. So here, they have an MLR of 80%, they have an MLR of 70%. The Affordable Care Act, the ACA, requires most insurance that cover the individual and small group markets to spend at least 80% of their premium income on health claims and quality improvement. And then only then, after that, can they spend it on marketing, profit, administrative. So this is a sense of trying to have some regulation of, okay, they spend it on claim versus other pieces.
So being able to spend the money on caring health of people versus administration, marketing, whatever.
Profit, et cetera.
Art?
Yeah, it would seem that is a huge and important number for the insurance companies. I mean, wouldn't that be
Sure.
kind of the biggest thing you're looking at? Unless they make money other ways. How else does an insurance company make money?
They make their money through premiums.
That's it, right?
They might have money, they might have investments elsewhere to help offset, but that's not the bulk of their income is providing a service.
Is there a percentage they look at? I mean, you probably can answer that more than anyone. I mean, is there a number where if it's less than that, you start to get in trouble as a company?
So Sarah Teachout from Blue Cross and Blue Shield of Vermont, we think this 80% that's in the federal law is extraordinarily low. And you should be buying health insurance that spends a lot more than 80% on your medical care, because that means they're spending another 20% on just other costs, administration, things like that. So Blue Cross, we're 92% MLR company, which means we spend 8% of premium dollars on processing claims, paying for employees in our company, paying for IT also includes all of our quality care programs, the nurses and doctors we have on staff to help do that. That all comes over in the so when you're shopping for health insurance, that's one thing to look at is how does the insurance company spend the dollars that I'm paying.
It includes salaries for everybody too, right, Brett? Okay, so 8% is what you folks, okay? All right, get back.
Well, you sort of astounded me with the 8% because I was looking at that. And wouldn't there be incentive? I mean, particularly if your administrative costs go up, you know, hiring more people, doing things like that, if you're capped at a certain percentage, wouldn't the inclination be to just try to spend more on claims to make incentivize services more? I mean, if you're up against that cap of 20% that you can only spend, then the only way you can get past it is to raise the 80%.
I understand the question. I don't have an answer. It's like
But then you said 92, and I'm like, yeah, no, they're not even anywhere close. But
It's really the operational efficiency of the company.
Yeah.
You know, if we are covering more people and charging more in premiums, then we need more employees and more, you know, IT and more things to make that happen. And the reverse is true. If a company is losing business, losing people that they're covering, then they need to shrink in order to right size the organization. And so MLR is just a measure of that sort of, you know, every business, whether it be an insurance company or not, has to do that.
Joe?
I was wondering, is there anywhere that we?
So I just want to make sure that Sarah is not here on the agenda. So let's go there. And it might be something that we put on our list for Sarah to come back and talk about.
Sounds good, thanks.
Yep.
Is there anywhere that we can look to see, since MLR is made up of two components, which is claims paid and quality improvements, is there anywhere that we can look at what is claims paid and what's quality improvement? And is there, as we were just talking about, healthy ratios and things like that, is there an amount that we ought to expect to be the claims paid part of MLR and the quality improvement part of MLR?
So it's a great question and it's got a complicated answer. The answer is awesome segue. It's a rate
So I'm here
review.
for just to move.
It's a great segue into rate review. So for our individual, small, and large group, the insurers have to file their rates with the Green Mountain Care Board. I don't know if you've met them yet or any of them yet.
Yes.
But in that piece, I mean, these documents, they're online. You can look at what they're asking for, and then you can see all the back and forth between their actuaries and everything's public posted. But these filings are super thick. But in those documents, they have all this is our MLR, this is what we expect, this is how many people we think we're gonna have. All that information are in that document. And, but it's not like it's easy to read because it's not designed for you and I to like really look at it. It's designed to be a very technical document written by actuaries for actuaries, you know? And ultimately it comes out in a way that, you know, in the end is the product for which you and I can understand, but getting into that weeds, like that's what's behind the curtain. So yes, I've spent a lot of time looking at those rate filings, looking for different pieces. And the answer is it's in there, but you have to know what you're looking for. And when you see something, you have to know what it is you're looking at. So the answer is yes, you can go into any one of those products. It's not like there's one answer, there's multiple products. You know, they've got gold plans, silver plans, you know, they have all these plans. And then they have, you know, small group, large group, they've got different things. So you'll see Blue Cross Blue Shield might have 30 filings for 30 products. And you can go in each of those products and get that answer, but it's not one answer. There might be 30 answers. Speaking of filing, so the carriers have to submit these filings to the Green Mountain Care Board. Usually what happens, usually what they are is the request of change in a rate for a particular health insurance product. So usually what happens is I showed you a standard, plan. Usually what they're doing is they're not introducing brand new plans every year. They're usually just taking an existing plan and updating it. Okay, this is the experience of that plan this year. This is what we think this plan is going to be this year. this is what we think the premium has to go up by this year. So that's what they're usually filing, is more often than not, they're saying, this is, we're just updating that plan. Now, do they introduce new plans? Sure, all the time, but usually more often than not, it's updated by an existing plan. Then you have a public comment period, that's 15 days. Believe it or not, people do respond. The advocate is a party to these things, so they're often a responder. Other folks are. Then there's opinion within 60 days. The Green Mountain Care Board must post an opinion of an actuary discussing the reasonableness of the rate and the opinion of the Vermont Department of Financial Regulation. So they have a role in this too, regarding the impact of the request rate on the solvency of the health insurer. So the Green Mountain Care Board looks at the reasonableness of the rate and does a lot of the actuarial work. The DFR wants to make, is tasked with making sure it's solvent, and they're looking at reserves. We talked about that amongst other things to make sure that the company is, solvent. There's a public hearing. You can go to those. You can, well, actually, they're not public. They're always public, but they're on Zoom now, and usually that's it can be an all-day affair with Blue Cross Blue Shield one day and MVP the other, where they come in and they'll say, okay, here's our rate filing. There's actuaries, there's lawyers, and they walk through what they're doing and why, and there's this whole back and forth. It's a very public process. And then the Green Mountain Care Board will decide whether to approve, modify, or disapprove a rate request within 90 days. They may be, I should say appeal, not appealed, to the Vermont Supreme Court within 30 days. So you might see in the news over the summer, Green Mountain Care Board, MVP is requesting on average a 10% increase in their premium. And that's like all their insurance, like all their exchange plan stuff. And then you might see a couple months later, a month later, Green Mountain Care Board approves a 5% increase. That's them looking at it. And then there's the dueling actuaries. And they're supposed to, they pushing back on the premium. We're trying to push down, but they have to justify why they pushed back on it. There has to be an actuarial sound argument for the reasonableness and why they said, well, we don't agree with Blue Cross or MVP on this X, Y, or the medical, whatever. So there is a whole process to that.
And as Nolan said, it's all on their website. So if you were interested to just see how it worked, you could go back and look at one from the summer and just read through and get a feel for the process.
And I actually look at them a lot of times when I'm working on something or trying to come up with a cost for something. I'll go look at some of those rate filings to get a sense of what they're doing. If I'm doing a bill on reserve or something like that, I might look and see, well, what did Blue Cross and MVP do in their filings? If you have the time and the interest, it can be it takes a little while to kind of understand. It's like reading legislation. It takes a little while to understand what it is you're looking at. But once you understand what you're looking at, it's actually quite powerful to be able to understand what's happening.
I just want to do a time check. I do want to be done at 4, so we have 5 minutes. So however you want to do the time.
Sure. So to talk about the board's role, they're tasked with determining if rates are excessive, inadequate, or unfairly discriminatory, and that's through their actuarial review. They have to determine if the rates are affordable, promote quality care, promote access to health care. That's, I believe, in statute. That's what their charges of what they're supposed to do. Protect insurance solvency, and is not unjust, unfair, equitable, misleading, or contrary to state law. I don't want to get too much into that. The board must also consider changes in health delivery, payment methods, amounts contributed to reserve, and other issues in its discretion. So the point is, these are some of the things that the Green Mountain Care Board has to look into when they're charged with doing when they look at rate review. And then the Office of Healthcare Advocate has in statute party status during the rate review. So if you were when they used to be in the room, you'd have the Green Mountain Care Board over here, you have the rate reviewer over here, and then you have Mike Fisher and his person over here, and they each have sort of turns, like interrogating or asking questions of the insurer. I should in the 4 or 6 minutes we have left, I should just probably touch on HSA, HRA, FSA.
I forgot about that.
But really what I'll just do is more importantly is I'll just refer you to this chart because, I still get confused. HRA, HSA. I think this chart and actually these definitions kind of explain it pretty well. So I think for time's sake, I'll just say, without getting detailed, I encourage you to just take a couple minutes on your own time to read these 3 slides on your own, because this is a conversation about, in terms of the continued evolution of what premiums are looking like, particularly for small business.
Absolutely.
I think on that, I might just,
I know, thank you.
that was
And
that was hard. That was messy, I'm sorry.
No, it's not easy to talk through. Are
C-
there any
on my case.
last
Oh, no, you're good.
comments?
Thank you for hammering for
Be close.
cleaning up the mess when I was like,
Thank you both. This is the last time we'll
Sarah.
talk about
Thank you,
these
Sarah.
things. And we will be having Department of Financial Regulation in as well as our insurance carriers on the exchange. They were supposed to be Friday. I think we're gonna have to switch that because of the AA, but we'll make sure we get them in so you can hear from them directly. So that's it for today, and we'll be back here at 9 a.m.